All right, let's get right into it. We've all seen those crazy disaster scenes in movies, right? But what really happens inside a hospital when the absolute unthinkable goes down? This isn't about Hollywood drama. This is a practical, behind-the-scenes look at a hospital's actual playbook for surviving a mass casualty incident, all based on established, life-saving protocols. Everything we're about to talk about, it all boils down to this one simple, brutal equation. This is the rule that defines what a mass casualty incident, or MCI, really is. It's that exact moment when the number of injured people just completely overwhelms the hospital's ability to give normal care. And when that happens, well, the rules have to change, and they have to change fast. So put yourself in this scene. You're the attending physician on duty. It's a normal day. Then the call comes in. A partial stadium collapse. They're estimating over 150 casualties. And your hospital? It's the closest one. In that single instant, you are no longer just a doctor treating one person at a time. Your entire world just flipped upside down. Your role has instantly pivoted. You're not just a clinician anymore, you're a tactical leader. Your job now is to manage a massive crisis, making split-second decisions that are going to affect dozens, maybe hundreds of lives. Chaos is at the door, and the only thing standing between it and you is a practiced, disciplined plan. So what does that brutal equation from before actually look like in official hospital terms? This. An MCI gets declared when your emergency department isn't just full, it's forced to operate at 20% above its absolute maximum capacity. It's a tidal wave of patients that's threatening to swamp the entire system. But here's the thing about this chaos. It's not totally random. It actually arrives in a predictable pattern, something they call the dual wave phenomenon. First up, you get the walking wounded. These are the folks who are hurt but can still get themselves to the hospital. Then, maybe an hour or two later, that second wave hits, and that's the critically injured, arriving by ambulance. Understanding this rhythm is absolutely crucial to getting ready for what's coming. Before that first wave even hits your doors, you've got this tiny, precious window of time. We are talking about maybe 15 minutes. And this is where a framework called 15 till 50 kicks in. It's basically a high-speed checklist to get the hospital ready for the first 50 patients before they even arrive. This is no time for making things up as you go. You grab the hospital's disaster binder and you start running through these 10 steps. Boom, boom, boom. You're doing things like reverse triage, which means quickly and safely discharging any patients you already have to free up beds. You're setting up triage outside the building. It's all about creating space and control before that first wave crashes down. And that brings us to maybe the single most critical part of any MCI, triage. This is where doctors and nurses have less than a minute per person to make these gut-wrenching decisions about who gets care right now, who can wait, and who can't be saved. The goal isn't to save everyone, it's to do the most good for the most people. For years, a method called START was pretty common, but today the gold standard is something called SALT. And the big difference is that L, life-saving interventions, and that is a total game changer. It means the first person on scene doesn't just sort people, they can act. They can apply a tourniquet, open an airway right there on the spot. It's about stopping preventable deaths in that first critical minute. So in practice, SALT is just brutally efficient. First, you sort. You literally just shout, "Everyone who can walk, move over there." Boom. Those are your green tags. Then you assess everyone left, focusing on those who can't move. While you're doing that, you are performing any immediate life-saving interventions. And then finally, you tag them with a color. This right here, this is the language of disaster. Every single patient gets a color. Red is immediate. They need surgery or help right now or they will die. Yellow is delayed. They're seriously hurt but stable enough to wait a bit. Green is minor. Black, well, that means deceased. And then there's gray, expectant. It's a devastating category for patients who are so critically injured they're unlikely to survive even if you had all the resources in the world. Okay, so once patients are tagged, you can't just have them all sitting in a big chaotic area. The next step is to bring order to that chaos. You physically transform the emergency department, dividing it into color-coded treatment zones. This creates a controlled flow, moving patients to the right place based on their priority. Now, this whole system only works with extreme role discipline. Look at the MCI triage MD. Their job is to sort and tag. That's it. They do not treat patients. If they stop to treat one person, the whole system backs up. Everyone has one specific job. The charge RN is like the mission commander for beds. The disposition RN is focused on getting stable patients out. And the flow RN, they're basically the air traffic controller for the sickest of the sick, the red-tagged patients. But what happens when the surge is so big, so overwhelming, that even this incredibly disciplined system starts to break? This is when we enter the grim reality of an MCI, the point where the demand for everything, staff, beds, blood, ventilators, completely and utterly outstrips the supply. See, the standard of care actually shifts. First, you enter what's called contingency care. You're adapting, right? Putting 2 patients in one room, that sort of thing. But then there's crisis care. This is when the resources are gone and the entire ethical equation flips. The goal is no longer about doing what's best for each individual patient. It's about doing what's best for the most people, maximizing the number of survivors, period. And this leads to truly impossible questions. You have only 1 ventilator left. You have multiple patients who will die without it. How do you choose? These are the agonizing, real-time ethical nightmares that clinicians face when a system gets pushed way beyond its breaking point. So we've walked through the playbook, right? But theory is one thing, and the chaos of reality is something else entirely. Let's finish up by looking at the tough lessons learned from actual events, the common points of failure that even the best disaster plans can overlook. These are the blind spots. Yeah, there are 3 major risks that can totally derail an MCI response. First, a communication blackout. What happens when the Wi-Fi gets overwhelmed and the electronic medical records go down? Second, that very human fixation trap we mentioned, where one doctor gets sucked into treating one person while 20 more are waiting. And finally, you get systemic friction, the reverse triage pushback, where other departments in the hospital resist taking on patients quickly because it disrupts their own flow. And that really brings us to the final critical thought here. What all this makes clear is that just having a plan sitting in a binder on a shelf is not enough. It's really easy to just assume our local hospitals are prepared for anything. But the real question, the one you have to ask, is, has that plan ever been truly tested? Has it been pushed against the pressure, the chaos, and the very human weak points that only show up when disaster actually strikes?